The first most important thing is how long it takes for you to either get a second head and neck cancer or a recurrence. If it's more than 2 years from your first radiation, you're automatically in a better prognostic category. And then of those better patients, if you've had surgery and you've had that cancer taken out and you need post-operative reirradiation, which we don't talk about as much, those patients did incredibly well with a 2-year survival of 60%, which is incredible for this group of patients. On the other hand, that's class 1. Those are our best actors. On the other hand, our poorest performing patients were patients their cancer, either they got a new cancer, the cancer came back within 2 years. And by the time we met them, before we did reirradiation, they either had a permanent feeding tube or a breathing tube, a trach or a PEG, which means they had impaired function. Something about their treatment or their tumor really impacted them in a significant way. And those patients with the same reirradiation, their 2-year survival was only 16%. So you can see 61% chance of being alive at 2 years, 16% being alive in 2 years. And everybody who didn't fit those categories was somewhere in between, which was about a 40% survival in 2 years. So automatically, to just break people up basically into a 20, 40, and 60% chance of being alive in 2 years, already oncologists' minds are racing with, for these people, we should be really, really aggressive, and it's probably worth a lot of aggressive and even risky interventions because they can live, some of which were cured long term. For these people, maybe the goal is ensure higher quality of life in the near term, maybe don't subject them to long courses or high risk treatments because they may not do so well. So that RPA, I think, is going to really define a new standard of care for every patient an oncologist sees in the office to help start the decision-making process.